Welcome to the class. Today's topic is hemophilia. Introduction. Hemostasis is a vital mechanism to prevent blood loss and to maintain vascular integrity, but it is also paramount for preventing invasive microorganisms from entering the bloodstream. The body protects itself from bleeding by producing a sticky blood cells called platelets. There are about 150 to 400 billion platelets in a normal liter of blood. In general, people, these sticky cells pluck any cuts or grazes, then release chemicals that activates biological molecules in the body, mainly thromboxane A2, TXA2, and serotonin, which enables the blood to form a clot through the process called blood coagulation or blood clotting. It is a cascade of enzymatic reactions of zymogen and proteinase and production of fibrin and stop bleeding. Figure 1. General pathways in blood coagulation. The different components that were present in the plasma activated by another and then later activate the next so as to furnish the blood coagulation. Such a cascade could be hampered if any one of the factors is absent or defective, leading to abnormal condition, unable to clot or bleeding disorder. Prothrombin time PT and the International Normalized Ratio INR, which were introduced in 1983. Prothrombin time PT test measures the amount of time it takes for blood plasma to clot. Prothrombin, also known as factor 2, is just one of the many plasma proteins involved in the clotting process. A basic understanding of the coagulation pathway is required to interpret prothrombin time result. The prothrombin time is a measure of the integrity of the extrinsic and the final common pathways of the coagulation cascade. This consists of tissue factor and factor 7, 2, 5, 10 and fibrinogen. The test is performed by adding calcium and the thromboblastin, an activator of the extrinsic pathway, to the blood sample, then measuring the time in seconds required for fibrin clot formation. To enhance standardization of PT in the patients receiving warfarin, the World Health Organization WHO introduced the International Normalized Ratio or INR in 1983. The INR calculated using the following formula: INR equal to patient PT divided by mean PT to the power ISI. In this formula, patient's PT is measured prothrombin time, mean PT is geometric mean PT of at least 20 healthy subjects of both sexes tested at a particular laboratory, and the ISI is International Sensitivity Index that is specific to each reagent instrument combination. Blood plasma normally takes between 11 to 13.5 seconds to clot if one is not taking blood thinning medication. PT results often are reported as an international normalized ratio INR that is expressed as a number. A typical range for a person not taking blood thinner medication is 0.9 to about 1.1. For someone taking warfarin, the planned INR usually between 2 and 3.5. If individuals' blood clots within the normal amount of time, they probably don't have a bleeding disorder. If they are taking blood thinner, a clot will take longer to form. If their blood does not clot in the normal amount of time, they may be on the wrong dose of warfarin, have liver disease, have vitamin K deficiency, have a bleeding disorder such as factor 2 deficiency. Figure 2. The cartoons to display the differences in the cascade reaction in normal and hemophilic individuals, just like the place of standing dominoes. Hemophilia is the name given to an increased bleeding tendency in hematology. Contrary to popular belief, this does not mean patients are liable to bleed to death from a minor cut. Neither would patient bleed faster than other people if get injured. The disease is X chromosome linked and inheritance is crisscross mechanism. The males are affected by this disease and females are the carriers. There are two types of hemophilia. Hemophilia A, presence of defective factor 8, and hemophilia B, presence of defective factor 9. Figure 3. The inheritance of hemophilia from generation to the next. Hemophilia A and B are congenital bleeding disorders caused by defective production of factor 8 hemophilia A or 9 hemophilia B, are sex-linked recessive inheritance. Female carriers are rarely symptomatic. Queen Victoria passed the disease on to her great-grandson Alexis, son of the Tsar, contributing to the fall of Tsarism in Russia. Pathophysiology. Factor 7 activated by thrombin and 9 activated by TF or factor 7A complex together activate factor 10, leading to thrombin generation and conversion of soluble fibrinogen to insoluble fibrin. Hemophilia A and B are disorders characterized by inability to generate cell surface associated factor 10A. Genetic abnormalities include inversion within intron 22 of factor 7 gene in 50% point mutation and deletions. Gross gene alteration common in hemophilia A but infrequent in hemophilia B. This may account for low frequency of inhibitors in hemophilia B. Third of hemophilia B patients have dysfunctional molecule. Carrier detection and antenatal diagnosis now possible in many cases by direct gene mutation detection. Affected family members are usually required. Linkage analysis no longer recommended as first line method. The gene for clotting factor 8 is located on the long arm of the X chromosome XQ28A. Hemophilia B has a mutation at the chromosome locus XQ27.1 Q27.2. It is 186 kilobases in length with 26 exons and 25 introns. Inversion of intron 22 accounts for 50% of all severe cases of hemophilia and is present in 20% of all cases. Approximately 30% of the mutations in this region are de novo. In the case of inherited hemophilia, males within the same family have the same level of deficiency since they share the same defect. The gene for clotting factor 9 is 34 kilobase in length and composed of 8 exons and 7 introns. De novo point mutation account for majority of abnormalities in this gene that lead to hemophilia B. Coagulation is a complex series of chemical reactions that allow body to form a clot to prevent the further loss of blood. Factors 8 and 9 are located in the intrinsic arm of coagulation cascade. The absence or decrease in level of either of these factors will arrest the clotting process, leading to prolonged bleeding. Epidemiology. Hemophilia A occurs in 1:10,000 male in UK. That is approximately 1/3 cases no family history as new mutation. 5 times more frequent than hemophilia B. No striking racial distribution. Clinical presentation. Hemophilia A and B clinically indistinguishable. Symptoms depend on the factor level. Bleeds into muscles, spontaneous bleeding into arms, legs, or any side may lead to nerve compression, compartment syndrome, and muscle contractures. Hematuria is common. Retroperitoneal and CNS bleedings are life-threatening. Severe disease. Plasma level less than 1% usually presents in the first years of life with easy bruising and bleeding out of the proportion to injury. Moderate disease. 1 to 5% factor level, intermediate and variable severity, or mild disease greater than 5%. May only present after trauma, surgery, or in later life. General features. Hemaarthrosis, spontaneous bleeding into joints, first knees, elbows, ankles, hips, wrist, produce local tingling pain, later swelling, limitation of movement, warmth, redness, severe pain. Diagnosis. Assess duration, type of bleeding, exposure to previous trauma or surgery, and family history. Look for bruising, petechial hemorrhages, early signs of joints damage. Exclude acquired bleeding disorders. Laboratory test. PT normal, AP-TT increase depending on degree of deficiency. Note: a normal AP-TT does not exclude mild disease. Assay 8 first, then Assay 9. Table 1. The comparative studies between normal and hemophiliacs regarding the factor 8 and 9 percentage in the blood. Radiology. Acute bleed, USS or CT scan if in doubt. In established disease, chronic synovitis, arthropathy, and other pathological changes seen. Hemophilia management. General regular medical and hemophilia review and lifelong supports are essential. At presentation, establish blood group, liver function, and baseline viral status. Vaccinate against HBV and HIV if not immune. Regularly check inhibitors status, LFTs, FBC, avoid aspirin, antiplatelet drugs, and IM injections. Early treatment of bleeding episode is essential. Prophylaxis is preferable to demand treatment for many patients with severe hemophilia. Prophylaxis started in first year or 2 of life. can prevent most, if not all, joint damage and almost eliminate significant bleeding. Factor concentrate need to be administered every 2 or 3 days. If not on prophylaxis, home demand treatment is preferable to the hospital demand treatment. Associated disorders. Both hemophilia A and hemophilia B are associated with disorders that involve other defects in the coagulation cascade. Other conditions that should be considered in those with bleeding problems are von Willebrand's disease, acquired hemophilia, other clotting factor deficiencies like factor 7, 5, 10 and 11, or platelet disorders. The identification of these other conditions has important prognostic and treatment implication. Special consideration. Antenatal diagnosis. Carriers can be identified by genetic mutation analysis. Antenatal diagnosis in carriers with male fetus ideally performed by chorionic villus sample DNA analysis at approximately 10 weeks gestation to allow termination of pregnancy. Rarer nowadays because of improved treatment and prognosis. Issue is complex and counseling testing should be at comprehensive care center. Home treatment has transformed the life of hemophiliac. Parents, the local GP, the boy himself from age 6 to 7 onward can be trained to give 4-factor concentrate at home. Treatment usually starts in the first year or 2 of life, and Potacate may be needed until age 4 or more. Prophylaxis. For example, 3 times weekly injection of concentrate. Average dose 15 to 25 U per kg given at home. Specialist support. Physiotherapy plays key role in preservation of muscle and joint function in patients with hemiarthrosis. Combined clinic with orthopedic surgeons, dental surgeons, hematologists, pediatricians, ISFE physicians and geneticists are required to give comprehensive care. Now, conclusion. To decide the individual is having bleeding disorder, PI is performed. Any deviation from the normal range of PI, the individual might having bleeding disorder. The bleeder's disease or hemophilia is of 2 types, A and B, caused by mutation in sex chromosome and is a recessive disease. The presence of defective factors of coagulation process, factor 8 in hemophilia A, 9 in hemophilia B, delay the process of coagulation. Many signs and symptoms include pain followed by swelling in a weight-bearing joint such as knee, hip or ankle, hemiarthrosis, spontaneous bleeding into joint spaces, etc. The disease is not curable till now, so management and injection or oral consumption of available coagulating factors are the only options. Hence, proper management are much for these diseases.